Hello, hello, hello. So Jess, are there still people on the team who are under quarantine?
We have one more.
Yeah. My daughter's at Greenville. Her two roommates are softball players. Baseball and softball. One gets diagnosed, they all go in quarantine.
Yep.
Which means that since she is their roommate, she goes on quarantine too.
Yeah.
She's quarantined 3 times last year. Yeah. And then she's dating a baseball player. Well, first time she was exposed to him, so she went on quarantine. Then she was exposed to her roommates and went on quarantine. Then she was exposed to a tennis player because she plays tennis. Then she went on quarantine again. She spent half the bloody semester in quarantine. Oh, Zach, not you too. Oh dear. Okay.
Yeah, we'll be out till next Tuesday.
Well, I suppose it was your turn.
Yeah, one of our coaches got it, so we're out till next Tuesday.
Okay, let's get started. Morning, everyone. Nice to see some of you off quarantine. I've not seen you yet, so welcome to this class in person. We have other people kind of transitioning onto quarantine, some transitioning off. So it's a bit of a carousel these days, but oh well, we'll get through it. If you do find yourself on quarantine through circumstances not under your control, I will try to get quizzes to you via email. If you happen to come back and you were gone on that Friday, see Mrs. Schaefer in the Natural Sciences office. You all know Mrs. Schaefer? Yes, everybody loves Mrs. Schaefer. Kathleen, and she will, although she goes by Kathy, and she will administer the quiz to you. Please try to get the quiz taken by Wednesday of the following week. Make that your goal to do that, please. Because it happens every year. I go through the grades and I see someone with a 0 on a quiz because they didn't take it. That's 20 points you could have had that you just don't have because you forgot. That's not a good reason to not have those points. So try to get that done. Try to keep up with it. If circumstances kind of pile up and you're just not able to do it, let me know. Keep me in the loop, and I'll do my best to try and accommodate you as best I can. Again, we have to be patient this semester. That's all we can do until everybody gets vaccinated, and then we can get rid of these wretched things. I don't know about you, but I'm kind of done with masks. They help. They work. I'm not anti-mask by any stretch of imagination. I've had several arguments on Twitter with people with whom I was wasting my time. And I'm not anti-mask, but I'm no lover of them. That's for sure. They're a pain. They're a pain. I don't like them. But especially in the gym, you start sweating and then they get really wet and it's just disgusting. Anyway, yeah. So if you have any questions, just please let me know. Office hours or same time, you can come see me. If you can't come during office hours, find another time and you can come see me. And I'm not hard to find. I'm part of the furniture around here. Okay? Any operational questions before we dive in? No? All right. Let's start with a word of prayer. Our Lord, we thank you for this cold day. Thank you for this semester and those who come back. We pray you'd help us to live smartly and to stay away from this infection that is ravaging not just our country, but the world. We pray the vaccine goes out, that it works, that it gets into lots of arms, and that we win this race between variants of concern and the vaccine. And for us, Lord, watch over this beautiful place and every student here and do the same. Amen. All right, we are talking about pharmacokinetics, and we talked about clearance. We saw that clearance clearance is going to be dependent upon the concentration of the drug in the plasma usually, but clearance also includes other modes of clearance through the body. You could get rid of it if the drug is volatile by exhaling it. You can sweat it out in some cases. It can be excreted in tears sometimes. Some drugs are excreted in bile, so they will be excreted from the GI tract. Most drugs will be cleared renally, but very often that's not the only mode of clearance. So clearance usually will be the renal clearance plus the clearance you might get from the liver plus the clearance you might get from something else. And it varies. Some drugs will be pretty exclusively cleared in one way, others will be cleared in multiple ways. So clearance is multifaceted for drugs. Now, the majority of drugs will be cleared according to their concentration. The more concentrated they are in your body, the faster your body gets rid of them. That's called capacity limited clearance. And you see this as the drug gets at its peak, the drug is being cleared at its fastest. Then as the concentration decreases, the drug is cleared less quickly. And that's usually the case for most drugs. There are some drugs that are metabolized by the liver. And so their exposure to the liver determines their clearance. So the clearance then is a function of how efficiently the blood flushes the drug through the liver. That's called flow limited clearance. There's a handful of drugs that are metabolized in this way, and it includes morphine. And these drugs here, the biggies here, are going to be morphine, and then some of the other opioids that we'll deal with. Verapamil is a drug we'll talk about. That's a very important drug both for blood pressure, but it's used also as an antiarrhythmic drug if you have a arrhythmia problem, so-called class 3 arrhythmia drug. And then you have some drugs that are used to treat tuberculosis, like isoniazid, antidepressants like these three, imipramine, desipramine, amitriptyline, and then lidocaine, which is a topical anesthetic. And when it goes to the liver, it is broken down very, very quickly. Therefore, topically, when it gets into the bloodstream, it's just not going to exist very long once it goes to the liver. So these handful of drugs, the ones I want you to be aware of are the opioids. That'd be this one, meperidine. That goes by the trade name Demerol. You heard of Demerol before? That's Demerol. And morphine. And then pentazocine is also a opioid. These are the three that'll be important for us. And then also propranolol and labetalol for this class, because those are blood pressure medicines, beta blockers, and then verapamil. Pretty much the others on here you can just ignore for now. So on page 9 of your notes, you have some equations. And these equations are ways in which you can estimate various parameters for a drug. So you can calculate the clearance based on this equation here. The rate of drug elimination divided by the plasma drug concentration. I said page 9. Sorry, page 9. And then renal clearance, metabolic clearance, so on and so forth. All of these are parameters you can calculate based on things you can measure. So that table on the very next page, the table here that goes on for a few pages, these are all things that are calculated using the equations that you find on the previous page. So these, therefore, are not guesses. These are actually measured. And they're measured usually with a good deal of precision. So because of this, you, now, if I want you to calculate something on an exam, I will give you the equation. I don't want you having to memorize equations. most of pharmacists, unless they use them a lot, don't have these memorized. They look them up, then they use them. Or they'll have them on a little card right above their desk. You don't need to memorize it. Not even professionals memorize it. So I will give you the equation. I just want you to know how to use it. That's all I'm going to require. No memorizing equations, just knowing how to use them. And so for the first test, first midterm, which will be at the end of the month, you will need to bring a calculator to the midterm. So mental note, bring calculator. I prefer you not use your phone, but if that's the only calculator you have, okay, you can use your phone. It's just, phone ends up being a big temptation to get on Google. And so I'd rather not go there, but yeah, whatever. If you need a calculator, that's not your phone, we can supply one. The department has a big vat full of calculators I can bring. So something to start thinking about even now. All right, so here is a way to calculate the volume of distribution, which is the very unfortunate abbreviation of VD. Valentine's Day, right? No? Okay, well. So the volume of distribution can be calculated with the amount of the drug that you give, that you administer, divided by the concentration of the drug in the drug plasma. Concentration of the drug in the blood plasma, which you can measure. And the amount of the drug, you know how much of the drug you gave. Then we get the very important half-life. Half-life. So this is the time from the dose that you gave, the initial dose, during which the amount of the drug in the body is reduced by half because of elimination or metabolization or whatever. So you reduce concentration by half. That is the half-life. In physiology, we have this other related concept you might have heard of, maybe not, called residence time. I don't know if any of you have heard of a residence time. Residence time refers to how long something stays in the blood at any concentration. So don't confuse a half-life with a residence time. Because a residence time, the drug or the compound might be in the blood, but it might be at a concentration where it's not active. So residence time and half-life, they're not the same. Not the same, don't confuse them. If you read about that in the paper, don't say, oh, it must mean half-life. Nope, not the half-life. Now the half-life can be calculated using this equation. So your volume of distribution, which you can calculate using the equation found on page 9, times this constant, and then divided by the clearance. Mind you, that's total clearance. Total clearance. And that can give you the half-life of the drug. Now, let's put this together and see what happens when you administer a drug. So take a look at page 7 in your notes. All right, so you have those two graphs on page 7. So this is actually taken from a paper. This is an actual measurement of a drug. The drug is the asthma drug, theophylline. You infuse it intravenously. So you give an initial bolus of the drug. It goes whoosh in the veins, and then you turn off the pump. When you turn off the pump, you then get these two numbers. Now, this B over here, that's what you would predict based on equations. What you see in A, that's what you actually measure. That's what you actually measure. So you have your observed. Sorry, no. You have I'll get this right. So the line, you have a dashed line and then a non-dashed line, solid line. So the solid line, that's observed, dashed line is predicted. One is a linear plot. So A, that's a linear plot. B is a semi-logarithmic plot. So look at that and tell me what you see. When is elimination the fastest? Is it the fastest at the beginning or at the end? That's the beginning. That's an example of capacity limited clearance because it is nice and fast towards the beginning, then it kind of slows down. So it's dependent on the concentration. That's a really common graph when you have a capacity limited clearance of a drug. Now, take a look at the next page, page 8. This graph on top, that's what you would see with an oral dose. So with an oral dose, because you don't have a needle in your vein and you don't have this big bolus of drug in the vein, the drug has to be absorbed. So it's absorbed, you get a nice big summit, essentially, of the graph, and then down it goes. And if you get below a certain concentration, you won't be at therapeutic levels anymore, potentially. That's why you would potentially need to redose the drug, but that's essentially what it's going to look like for an oral dose. There's a lag between when you give the dose and when you get your peak concentration. Whereas with intravenous drugs, you get your peak right away, and then as you keep putting drug in, you can get a steady state. Whereas fast as your drug is put in, it's being eliminated, provided you've titrated the administration. Now, this graph below here, that essentially shows you what happens as you start to infuse a drug. So A is your infusion, and then C essentially shows you the tendency for the drug to be degraded once you shut the infuser off. Notice that there's a point at which these two graphs will cross. That point at which these two graphs will cross will be actually pretty close to the half-life of the drug. And that's one way, essentially, you can estimate. It's not a perfect estimate, but that's one way to estimate drug half-life. Sure. So the middle graph there shows you in A, you essentially start infusing the drug, it starts to build up, and as you constantly infuse it, essentially, that's what you get. And if you keep infusing it, that graph would just continue to go like that. C and B essentially would be this, if you were to give, say, there's a dose you give that's called a loading dose sometimes. So say you didn't want this lag from here to here, you just give this wham, big bolus, it gets you up here. And by the time that gets broken down, this is already up here. That would be that constant level of drug with a loading dose. Or this essentially would be this graph once you extend it out to here. If you shut off the infuser, now here's what happens as the drug starts to get eliminated. So infusion, elimination, and infusion with a loading dose. Let's take a look at an orally administered drug here, excuse me, not orally. This will be a drug that will accumulate during a constant rate of infusion. This shows you the elimination after a constant rate of infusion and steady state has been reached, but then the infusion is stopped. So that essentially looks a whole lot like what you have on this middle graph here on page 8. So these two places where those two graphs cross, that's your half-life. That's your half-life. And here is a pharmacological rule of thumb. In order to achieve maximum effect, it'll take you usually about 4.5 or so half-lives. So usually it's 4 to 5 is what you'll hear. 4 to 5 half-lives. So your bioavailability, as we said, is that fraction of the drug that's unchanged in the circulation following administration by any sort of routes. And we saw that the bioavailability is going to vary given the different modes of administration. So for intravenous administration, it's 100% by definition. For intramuscular, it's going to vary. Usually when you give a depot shot of an intramuscular preparation, some of that material may precipitate in the muscle and be unavailable for circulation. Some of it may not be taken up very well. Some of it may be degraded by the muscle cells themselves. So intramuscular will vary. Now you guys are way too young to remember when I was a kid, and if you had strep throat, the doctor gave you a shot in your glute of penicillin G. Penicillin G is very poorly soluble. That's why giving it as a pill is impractical. It won't be absorbed. Also, it doesn't pellet. But penicillin G is a terrific medication to give intramuscularly. It's released by the muscle very gradually. You get a constant concentration of penicillin G until it gets used up, and virtually all of it gets absorbed. That's a great way to treat strep throat back then, although it sure gave you a sore tuchus, that's for sure. Other drugs don't do as well. So that's why it's 75 to 100. Now, question for you. What happens to muscle mass in older people. Decreases. What happens to intramuscular bioavailability in an elderly person then? It's erratic. Its release is very erratic. For that reason, IM administration in elderly people is discouraged because of its unpredictability. Same goes for infants. Release is very erratic from infants. Subcutaneous. So to understand the subcutaneous skin, just take the back of your arm and just pinch like that. And then that area upon which the skin moves, that's your subcutaneous layer. And that's literally how you give a sub-Q injection. You pinch the skin and you slide the needle right under that, and you put a little bolus of drug in that subcutaneous area. So insulin is administered subcutaneously. The sub-Q is very, very rich in blood vessels. Its bioavailability tends to be high. For some, it's not quite as high. Oral is going to vary wildly. So acyclovir, which is given for herpes infections, acyclovir is not very soluble, and its bioavailability is terrible. That's why if you give a tablet of acyclovir, you could pretty much bet that only a fraction of it is going to go to the circulation. Then let's take a drug like doxycycline. Doxycycline orally is virtually 100% bioavailability. Very, very good bioavailability. So oral, very convenient, but it's going to vary wildly. And you can see that on your table. There's a bioavailability column. If you just eye that going down, you could see that it's pretty variable. Very extensively variable. We've got 35 to 100 to 90 to 65 to 23. That's acyclovir, and on and on and on and on. So oral, very convenient, but problematic. Rectal. Rectal is very good for some drugs, but again, it's going to vary because it depends upon the release of the drug from the vehicle. Most of your rectal suppositories are usually encased in wax. So your drug has to be mixable with wax. If it's not, you got a problem. Do you use suppositories in babies? Never. Reason being, because of the structure of the baby's lower bowel, depending upon where you put the suppository, the absorption will vary wildly. So again, it's erratic also. Babies have a bowel that works quite regularly. And so you put in a suppository, it gets ejected usually before you get much drug out. So suppositories are never used in babies. Inhalation. Problem with inhalation is most of the drug ends up in the back of your throat. Having said that, the drug that does get into your lungs gets absorbed very, very well. Yeah, we're going to see you can use this thing called a spacer that will increase efficiency. Problem with spacers is they start to grow stuff. A lot of people with spacers don't wash them. Also, There were 2 papers that came out 5 years ago. Turns out most people who use an inhaler don't use it right. So you can't hand someone an inhaler and say, be blessed, go use this, be well. You have to teach them how to use it. In fact, those of you who will become healthcare professionals, in fact, write this down. Have your patient or client take out their inhaler and use it and watch them. Because surveys showed that only 30% of people know how to use an inhaler properly. And if they're not using it right, teach them how to use it. Yes, that applies to chiropractors too, Allison. You're supposed to shake it. A lot of them don't shake it because it's a colloid in there. If you don't shake it, you're going to get all vehicle. That's not going to help you. Well, it'll help you go. Then you're supposed to push and then breathe in and then hold your breath. 1001, 1002, 1003, 1004, 1005. That takes it and lets it settle into the lungs. People do all kinds of weird things. They don't put their mouth on it. Some people play it like a trumpet, and that's not going to get a lot of air, a lot of it into your lungs. You'd be surprised on the variations. But first time I got an inhaler, I was 52. I never had an inhaler before. I had no idea how to use it. And I just looked at the pharmacist and I said, I know this is supposed to be obvious, but I'm not that smart. So can you please tell me how to use this? And she showed me how to use it. She showed me once and I was fine. But my mother, God rest her soul, in her later years had to use a nebulizer. We never got mom to use the nebulizer properly. I said, Mom, take your lips, put it on the mouthpiece and breathe in. Mom would put her lips here. Just, old dog, new tricks, just, yeah. Anyway, never could teach her how to do it. So just don't be surprised if people don't use it right. So that's part of the issue. And Katya, don't laugh. You're going to be a nurse. No, it's important. It's important. So inhalation varies because of the mode of delivery. Transdermal usually is very good. Very good. But the drug has to be soluble in a vehicle that you could put in an ointment that can go on a patch. Not many drugs are that way. So drugs like Daytrana, which is a patch for Ritalin, fentanyl comes in patches. There is a lidocaine comes in patches. There's a new antipsychotic, amisulpride, that comes now in a patch. It varies. Patches. 2 things about patches. One, if you're going to have imaging, take them off. There's metal in the patch. They'll screw up the imaging. 2, you're supposed to take off the patch, fold it, flush it down the toilet. Don't put the patch in the trash can. Because babies think patches are cool, and the ointment on them they think is really cool. There are babies who've died because of fentanyl exposure from patches. So if you have a client on a patch, be really, really concerned about the way they dispose of that patch. That patch could be a potential danger zone. That's really important. But patches, very good. You don't use patches in babies, by the way. The stratum corneum is very, very thin in babies, and the absorption is way too fast. For babies, 2, when they're 2, usually. That's most of them when they're 1, but 2 usually be safe. That's when things usually are fine. So if you have a slide with just this, that means it's really important. Different routes of administration will show distinct differences in bioavailabilities. And some of them will avoid that so-called first pass effect. All right, so bioavailability will depend upon the extent of absorption. That's going to be dictated by the mode of administration. It'll depend also on that first pass elimination. If you give the drug orally, and then the drug is degraded by the liver really quickly, there's a number that you can calculate called the extraction ratio for drugs with first pass effect. And this is also influenced by your blood flow through the liver. That's subject to a good deal of individual variation. So this is something you can calculate. Also the rate of absorption. Some drugs get absorbed quite quickly. Others not so quickly. It's going to depend. That affects bioavailability too. So if you take a drug orally and it enters the circulation from the gut, first place it goes is to the liver. And if the liver degrades the drug quickly, then the drug will not achieve therapeutic concentration in the circulation, and that's called the first pass effect. The first pass of the drug through the liver causes its extensive degradation. And that's the case for drugs like morphine and so on and so forth. If you give the drug intravenously, then the drug will be able to circulate through the body before it goes through the liver. That's why drugs that have a good deal of first pass effect, you can avoid that if you give them intravenously. Same goes if you give them, say, sublingually, or if you give them intrarectally, or something like that, because those modes of administration will avoid the first pass effect. Tremendously. Some drugs, you need to adjust them if the liver is dysfunctional, others you don't. And it depends on how dependent they are on liver biotransformation. So doxycycline, for example, you don't need to adjust that at all. Dabigatran, blood clot inhibitor, you don't need to adjust that at all. Metformin, the anti-diabetic medicine, if you have liver dysfunction, you can't even use that drug. So it depends on the drug. And there are equations that are available for that. Also, the drug companies, lots of times will have worked that out, and they'll tell you if liver function is this, give it this dose. If it's this, give it this dose, so on and so forth. That'll be in the drug insert that nobody reads. That comes with the drug, but you, the clinician, you better read it because it'll tell you all that. Some drugs get converted into metabolites, and those metabolites, in some cases, have action. In some cases, they may have most of the action. So, for example, fluoxetine, which goes by the trade name Prozac, the happy pill, fluoxetine is converted into norfluoxetine. Norfluoxetine is the compound that has a really long half-life. Prozac, you dose Prozac once a week because Prozac has a really long half-life. And norfluoxetine is a metabolite with most of the activity. Other times, the metabolites may cause side effects. So that's something to consider as well. The drug metabolites can complicate this sort of scenario. Now, drugs that are degraded by the liver, drugs that show that flow related clearance. They're going to show pretty high variations just because liver function is going to vary, even in healthy people, will vary from one person to another. That's why, for example, you can, if you've ever, have you had surgery before? When you come out of, when you're in post-op, what's the first question the nurse asks you? You don't remember, you're a kid. Okay, anyone else remember what the nurse asked you? Sorry? What's your name? It's on your, no, she usually asks you, what's your pain level? How's your pain? And if they filled you up full of local, usually you're just fine. But if you had morphine, which most people will have had during surgery, that morphine is going to be degraded at different levels. Some people will have pain, others won't. Also, some people will metabolize it so slowly, it's going to make them sick to their stomach. So they give you usually some toast. In England, they give you marmalade, which makes me sick anyway. So, oh, how do they eat that stuff? At least they don't give you Marmite. Ugh, disgusting. Anyone know what Marmite is? It's yeast paste. Yes, ugh, they love it. The British love it. Yes, no, no, hummus is good. Marmite is disgusting. Oh, it's just, ugh. Marmite smells like bird dung. I'm not kidding. It's, yeah, it's bad. Okay, anyway, so they give you marmalade in British hospitals. Here, they'll give you crackers or they give you toast and they're watching to see if you keep it down. If you upchuck it, then that tells them if the anesthesia is making you sick. That is a function of these different liver functions, even in healthy people. So that's something to keep in mind. Liver function can vary pretty wildly. This is due to just inherited differences that affect liver enzyme levels and blood flow to the liver. To keep you at the therapeutic dose, keep you at therapeutic concentration throughout the blood. That's why you would want to dose a drug multiple times. Now, I'm going to show you an example that's going to illustrate this point, but keep in mind the relationship between the effect of a drug and its concentration are often not linear. So here, for example, we have a blood pressure medicine called enalapril. You take 10 mgs, take it once a day. If you get this drug, you're told you can take it with food, without food, doesn't matter, but take it at the same time every day. Usually you take it in the morning, typically. So here is the amount of inhibition of this enzyme, angiotensin converting enzyme, that you get when you take the drug. So when you first take it, you get 100%, and then it starts to fall off during the day. And then by the time you're ready to take it again, you're at about 30 some odd percent of inhibition. And it was 100% when you first took it. Here is the drug concentration. You take it, you get this concentration, and then it starts to ebb gradually during the day. And you can see how you relate inhibition with the drug concentration. Now here you're at 0, yet you're still about 30% inhibition. Reason being, this inhibitor is a irreversible inhibitor, so the cell needs to remake this enzyme. It hasn't remade them all yet. That's why you're still at 33%, even at that point. So let's take some clues from this. So 3 hours after the dose, you have your peak plasma concentration of the drug, which is 64 nanograms per milliliter. That's a plasma concentration. 2, 7½ half-lives elapse from the end of the peak to the end of the dosing interval, 7½. Your EC50 is really low. So that's your EC50, that's your peak. See the discrepancy? Pretty extensive. And after 24 hours, target is still 33% inhibited. So the plasma concentration of the drug decreases 16-fold after the first 16 hours, but ACE inhibition only drops by 20%. So we can see that the relationship between biological effect and concentration are very often not linear. Some drugs have a lag time before they work. It takes time for the enzyme to turn over. It takes time for all the receptors to be bound. It takes time for the cell to divide or to stop dividing or to whatever, stop making such and such. And when it makes such and such, that such and such needs to turn over before the drug starts having its effect, something like that. Other drugs have to build up in the body before they cause their effect. Good example of this is cancer drugs. Another example, SSRIs. SSRIs, selective serotonin reuptake inhibitors, you have to be on them for at least 4 weeks before you start to see their effects, because they cause gene expression changes in neurons. So that neurons now make a certain type of serotonin receptor. And that certain type of serotonin receptor is necessary for the effect of the drug. That's why people sometimes on SSRIs, they take them 2 weeks, they say it doesn't work, they stop taking it. But you need 4 weeks to actually know if the drug is working, which if you're depressed is a big drag. It's going to take that long for the drug to start working, but that's the case. Now, other drugs will build up and that'll show their toxicity. So aminoglycosides are an example. Aminoglycoside antibiotics cause renal toxicity, but they have to build up before they do that. So with these drugs, you can give them, you can bolus them, but if they don't build up, you're not giving them that drug constantly, you can still use them provided they're not building up and causing renal toxicity and, for that matter, ototoxicity as well. That is, they cause loss of hearing. All right, so a maintenance dose, and Katja, this gets back to your question. The maintenance dose is that amount of the drug, the dose of the drug you give that will establish a steady state concentration. When I say steady state concentration, I mean average concentration in the body. Let me give you an example of what I mean by this. So here is an infusion. So it's 28 mg of the drug per hour. It builds up, you keep infusing. There's your steady state dose. Your concentration in the body is 10 mg per liter. That's your intravenous infusion, constant infusion. That's your maintenance dose of that drug. Now, let's say you leave the hospital. You don't want to leave with an IV bag attached to your back, do you? No. So you want to be given an oral dose of the drug. Now you get an oral dose of the drug that you get 24 hours at a time, and you take it, and it gets degraded, take it, gets degraded, take it, gets degraded, take it, gets degraded. Notice that the average dose in the blood is still 10 mg per liter. It just varies more than the intravenous, but the average is still that. That's your maintenance dose, 672 mg per day. Or you can give it 3 times a day. If you give it 3 times a day, 224 mg, 3 times a day, TID, then you get this sort of thing. Notice once again, your average is still 10 mg per mil. 3 different ways to dose, same average concentration in the blood. That's your maintenance dose. So your dose and your dosing rate will determine essentially that dose that you need to keep a therapeutic dose in the blood. All right, so with these 3 modes of administration, average or steady state concentration in the body stays the same. Very good. So the dosing rate is equal to the clearance times the target concentration. The clearance times target concentration. Target concentration is this number right here, 10 mg per liter in this case. That's what we mean by target concentration. And then the dosing rate times the dosing interval, that's your maintenance dose. That's how you calculate a maintenance dose. So let's give you a little sample calculation here. For theophylline, for asthma, our target concentration is 10 mg per liter, plasma concentration. Here's our clearance of theophylline, 2.8 liters per hour per 70 kilogram body weight. We're going to give it intravenously, so our bioavailability is 1. And then to calculate our maintenance dose, it's just clearance times the target concentration. And there we are, 28 mg per hour per 70 kilogram. That's what we set our infusion pump to, 28 mg per hour. Well, we'd set it actually for a volume because it's going to be dissolved in a certain volume, and that's what we'd set the pump to. The dosing rate will equal the infusion rate. Okay, now the guy leaves the hospital. We don't want him to suffer from asthma when he leaves the hospital, do we? No. So now we're going to take the dosing rate and divide it by the bioavailability, which for oral, theophylline will be different. Then we'll multiply that by our dosing interval. So here is our dosing rate. We're going to divide it by bioavailability. That's bioavailability for theophylline. Multiply by the dosing interval. We'll say have him take it twice a day. And there's our concentration, 350 mg, which he will take twice a day. Okay, your turn. Now we want to dose him 3 times a day. What is going to be the dose? And then what will be the dose for a 24-hour? Go ahead and figure it out. If you want to lean next person next to you, you can figure it out together. Go ahead. Get a number?
I did for the 8 hours. I don't remember exactly what the initial.
It's get a number? Okay, so for 8 hours. Okay, and for, yep. Mhm. Did you guys get some numbers? What numbers did you get?
233 for 8.
For 8 hours, about 230 some odd, something like that. And for 24, 700, which makes sense seeing that it'd be double this one, be 700. Yeah, so bingo, bingo, good job, good job. Now, for drugs with long half-lives, you might want to use a dose that gets them up to that therapeutic concentration right away. So you give them a bolus. That bolus is called a loading dose, a loading dose. And here's how you calculate a loading dose. You take the volume of distribution and you multiply it by the target concentration. And if you're giving intermittent doses, then you take the maintenance dose and then you multiply it by something called an accumulation factor for the drug, and that's published for each drug. So you are going to take a target concentration that you know will work. You can predict using those equations, clearance and volume of distribution. You use that to calculate your maintenance dose. You then measure the patient's response and the drug concentration in the blood. And then based on those measurements, you just revise these parameters and try again until it basically works. And that's essentially how you get your target concentration nailed down. Now, there are some features about pharmacokinetic values we need to consider. First of all, absorption. What if someone has an inflammatory bowel disease? What's that going to do to absorption? It's going to really cock it up, especially if they have Crohn's disease. Since most of your oral drugs are absorbed in the small intestine, if the small intestine is ravaged and scarred over by Crohn's disease, that's going to really decrease absorption. What if they have had some sort of bowel resection surgery? Say they had a Roux-en-Y or gastric bypass surgery, something like that. What's that going to do to absorption? That's going to decrease it as well. What happens to absorption in an older person? Absorption is an active process. Absorption goes down, but motility goes down too. So absorption, because those two things, they're going to kind of equal each other out. Absorption in an older person will be about the same. Now in kids, absorption is going to be erratic because stomach acid is not quite there yet. So if the drug is a weak acid, its absorption will be poor. If it's a weak base, its absorption might be even greater. If it's lipid soluble, they're not making a lot of bile salts yet. So their absorption will be not very good. So absorption in babies is going to be quite erratic. Clearance. Clearance will be affected by renal capacity. If they have any sort of renal compromise, that's going to affect clearance. We talked about volume of distribution already to some extent. And half-life therefore can be affected too if their liver function is not quite as it should be. All right, we will finish this on Friday and get into drug biotransformation. Okay, Zach, I'll see you on Friday.